Hello?
Hello, doctor. Hello.
Hindi yung phone mo. Teka.
Hello. Good
Okay,
morning,
can you hear
doctor.
me?
Hello.
Good morning. Hi, good morning.
Hi.
Morning,
Good
Doc.
morning po, doc.
Good morning to Doc.
Do I come clear yung
No,
sa
no, doc. Just
sounds?
chopping.
Sorry, I can't start a video because we're having internet problems. But can you choppy? Okay. Okay, but anyway, I can hear you. Maybe we can go on soon. Wait. I'll just type it.
Good morning, Doctor. Good morning, everyone. We are here to discuss about pathophysiology of fever and pain today. Next slide. Coming to pain, pain is universally understood as a signal of disease. It is the most common symptom that brings a patient to physician's attention. The function of the pain sensory system is to protect the body and homeostasis. It does this by detecting, localizing, and identifying potential or actual tissue damaging processes. Because different diseases produce characteristic patterns of tissue damage. The quality, types, and
Okay.
Because different diseases produce characteristic patterns of tissue damage, the quality, time course, and location of a patient's pain lend important diagnostic clues. Coming to the pain sensory system, pain is an unpleasant sensation localized to a part of the body. It is often described in terms of penetrating or tissue destructive process such as stabbing, burning, twisting, tearing, and squeezing, and or of a bodily or emotional reaction such as terrifying, nauseating, and sickening. Furthermore, any pain of moderate or higher intensity is accompanied by anxiety and the urge to escape or terminate the feeling. These properties illustrate the duality of pain. It is both sensation and emotion. Next slide. When it is acute, pain is characteristically associated with the behavioral arousal and stress response consisting of increased blood pressure, heart rate, pupil diameter, and plasma cortisol levels. In addition, local muscle contractions such as limb flexion, abdominal wall rigidity is often present. Next slide.
Peripheral mechanism. Peripheral nerve consists of the axon of three different type of neurons. First, primary sensory afferent, motor neurons, and sympathetic postganglionic nerve. The cell bodies of the primary sensory afferent are located in the dorsal root ganglia in the vertebral foramina. And the primary afferent axon has two branches. First, projectly centrally into the spinal cord, and the other project to innervate tissue. The largest diameter afferent fibers, group A beta, responds maximally to high touch or moving stimuli. These are present in nerve that innervate the skin, and these fibers do not produce a pain. These are two other classification of primary afferent nerve fibers. First, small diameter myelinated A delta, and second, unmyelinated C axon. These fibers are present in nerve to the skin and to deep somatic and visceral structure, or present in some tissue, for example, cornea, and innervates by only A theta and C fiber afferent. These fibers are response maximally to painful stimuli and also called primary afferent nociceptor and pain receptor. Next presenters.
Good morning, doctors. Begin with the nociceptor-induced inflammation. Primary afferent nociceptor also have a neuroeffector function. Most nociceptor contain polypeptide mediators that are released from their peripheral terminals when they are activated. Let's go. The events leading to activation, sensitization, and spread of sensitization of primary afferent nociceptor terminals. Let's begin with the first diagram. In the first one, direct activation by intense pressure and consequent cell damage. Cell damage induces lower pH and leads to release of potassium and the synthesis of prostaglandins and bradykinin. Prostaglandin increase the sensitivity of terminal to bradykinin and other pain-producing substances. In secondary activation, impulse generated in the stimulated terminal propagate not only to the spinal cord, but also into other terminal branches, where they induce the release of peptides include substances P, in where substances P cause vasodilation and neurogenic edema with further accumulation of bradykinin. Substance P also causes the release of histamine from mast cells and serotonin from platelets. Thank you.
The central mechanism involves the spinal cord and the referred pain. The axons of primary afferent nociceptors enter the spinal cord via the dorsal root. They terminate in the dorsal horn of the spinal gray matter as shown in the figure. The terminals of primary afferent axons conduct spinal neurons that transmit the pain signal to brain sites that is involved in pain perception. When the primary afferents are activated by noxious stimuli, they release neurotransmitters from their terminals that excite the spinal cord neurons. The major neurotransmitter they release is glutamate, which rapidly excites dorsal horn neurons. The axons of each primary afferent conducts many spinal neurons, and each spinal neuron receives convergent inputs from many other primary afferents. Because of this convergence and the fact that the spinal neurons are most often activated by inputs from the skin, activity evoked in the spinal neurons by input from deep structures is mislocalized by the patient to a place that is roughly correspond with region of skin innervated by the same spinal segment. Thus, the spatial displacement of pain sensation from the site of the injury that produces it is known as referred pain. The figure shown here explains the convergence projection hypothesis of referred pain. Next slide.
Now we are going to discuss about pain transmission and modulatory pathways. Here, figure A is pain transmission for nociceptive messages and figure B is pain modulation networks. Before going here, we can determine the terms. Here, F resembles to frontal insular and C is anterior cingulate and S is somatosensory cortex. When an injury happens, the message is transmitted over the peripheral nerve to the spinal cord, where it synapses with cells of origin of major ascending pain, the spinothalamic tract. This message is relayed in the thalamus to anterior cingulate, frontal insular, and somatosensory cortex. This transmission for nociceptive messages noxious stimuli activate the sensitive peripheral ending of the primary efferent nociceptor by the process of transduction. And figure B is pain modulation network. Here, inputs from frontal cortex and hypothalamus activate the cells in the brain that control spinal pain transmission cells via cells in the medulla. Next slide.
While talking about pain modulation, it refers to the process by which the body alters the pain signals as it transmitted along the pain pathway. The pain produced by injuries of similar magnitude is remarkably variable in different individuals. For example, the athletes known to sustain serious fractures with only minor pain, while many patients feel unbearable pain in even minor surgeries like venipuncture. So there are two pain modulations which include gate control theory, in which the pathway gives some collateral branches to the pain pathway that inhibits the sensation of pain. And another one is pain modulation is a descending analgesic system which modulates the pain through some endogenous opioids such as enkephalins and beta endorphins that triggered by spinal mesencephalic fibers, limbic system, and some sensory cortex. In fact, the pain relieving endogenous opioids are released following surgical procedures. So, the circuits that modulate the activity of pain transmission pathway include some anatomical regions of the brain, as you can see in this picture, such as hypothalamus, periaqueductal gray matter, periventricular gray matter, locus coeruleus, rostral ventral medulla, and reticular formation. Next slide. Neuropathic pain. Neuropathic pain is caused by damage or injury to the nerve that transports information between the brain and spinal cord from the skin, muscles, and other part of the body. The pain is usually described as a burning sensation, and affected areas are often sensitive to the touch. Lesion of the peripheral or central nociceptive pathway typically result in a loss or impairment of pain sensations. Paradoxically, damage to or dysfunction of these pathways can also produce pain. For example, damage to peripheral nerve has occurred in diabetic neuropathy or to primary afferent, as in Harper's cluster infection can result in pain that is referred to the body region innervated by damaged nerve. Next slide.
Pain may be also produced by the damage of central nervous system. For example, some patients following the trauma of vascular injury to the spinal cord, brainstem, or a thalamic area that contains the central nociceptor pathways. Such pains are termed as neuropathic and are often serves and are typical resistant to standard treatment of pain. Neuropathic pains typically has unusual burnings, tinglings, and electric shocks like quality and may occur spontaneously without any stimulus or be triggered by the very light touch. These features are rare in the other types of pains. Next slide, please.
So for acute pain, it is of short duration, which resolves when tissue heals. It acts as a warning sign for tissue damage, which correlates with the amount of damage. It sometimes results in anxiety and sleeplessness, but it improves when pain is relieved. And for the chronic pain, it persists despite tissue healing and is not a warning signal for damage, and it's not correlated with damage, often associates with depression. So for chronic pain, it's better to look for emotional and organic factors before initiating therapy. And once the organic cause is known, it's better to look for other factors. Thank you. Next slide, please.
Fever. Body temperature is controlled by hypothalamus. Neurons in both preoptic anterior hypothalamus and posterior hypothalamus receive two kinds of signals. One is the peripheral nerves that transmit information from warmth or cold receptors in the skin, another from the temperature of blood bathing in the region. These two types of signals are integrated by thermoregulatory center of hypothalamus to maintain normal temperature. Next slide.
In a neutral temperature environment, the human metabolic rate produces more heat than is necessary to maintain the core body temperature in the range of 36.5 to 37.5 degrees Celsius. And if temperature is greater than 37.7 degrees Celsius, which define a fever, the daily temperature variation appears to be fixed in early childhood. In contrast, elderly individuals can exhibit a reduced ability to develop fever, with only a modest fever even in severe infections. Thank you.
Fever versus hypothermia. Okay, let's compare fever with hypothermia. Coming to the pathophysiological mechanism, the inflammation of cytokines trigger the hypothalamus to increase the body's set temperature. Someone cranked it as the thermostat. Hypothermia. Excessive heat generation strips the body's ability to get rid of thermal energy. Body temperature increases beyond the hypothalamus set temperature. Hence, it is a body on fire. Typical examples in fever, also known as pyrexia, is infection or sterile inflammation. Example, pancreatitis. In hypothermia, it's exertional heat stroke and malignant hypothermia. Coming to typical temperature, it is usually below 41 degrees centigrade or 105.8 degrees Fahrenheit in fever, and it is often above 41 degrees centigrade or 105.8 degrees Fahrenheit. In clinical features, triggers can precede the temperature spike as hypothalamus is trying to increase its temperature. In hypothermia, there is a lack of triggers, rigidity, or increased tone can be seen in some of the situations. Extreme temperature can often lead to delirium. Effect of antipyretics in fever. One of the example is acetaminophen. It is often effective in reducing temperatures. But coming to hypothermia, this acetaminophen doesn't work as the acetaminophen works at the hypothalamic level. But here in the hypothermia, the hypothalamus is not under the control. Effect of physical cooling. For example, a cooling blanket. In fever, a cooling blanket is often effective. The hypothalamus wants patient to be warm, so adding a cooling blanket may merely provoke rigors and misery as the body continues to try to maintain an elevated temperature. In hypothermia, a cooling blanket is often effective and also necessary to reduce the temperature of the body. Physical cooling should not provoke distress or rigors as the hypothalamus is trying to get rid of thermal energy. It is simply unable to. Clinical implication and importance of temperature control in fever. Fever itself is rarely a dangerous unless unusually extreme or in the context of neurological illness. The key issue is to understand and treat the underlying cause of the fever. In hypothermia, it is itself and often immediately life-threatening extreme temperature may damage tissue. Aggressive control of body temperature is often essential in addition to address any underlying cause. The next slide, please.
Pyrogens. The term pyrogen is used to describe any substance that causes fever. Exogenous pyrogens are derived from outside the patient. Most are microbial products, microbial toxins, or whole microorganisms. The classic example of an exogenous pyrogen is the lipopolysaccharide produced by all gram-negative bacteria. Next slide.
Pyrogenic products of gram-positive organisms include enterotoxins of Staphylococcus aureus and the groups A and B streptococcal toxins, also called superantigens. One staphylococcal toxin of clinical importance is that associated with the isolates of Staphylococcus aureus from the patient with toxic shock syndrome. These products of staphylococci and streptococci cause fever in experimental animals when injected intravenously at the concentration of 1 to 10 microgram per kilo. Endotoxin is highly pyrogenic molecule in humans. When injected intravenously into volunteers, a dose of 2 to 3 nanogram per kilogram produces fever, leukocytosis, acute phase proteins, and generalized symptoms of malaise.
Pyrogenetic cytokinase. Cytokinase or small proteins, molecular mass 10,000 to 20,000 data that regular immune, inflammatory, and hematopoietic process. For example, the elevated leukocytes is seen in a severe infection with an absolute neutrophil is attributed to the cytokinase, intraleukin IL-1 and IL-6 tumor necrosis factor, which is called TNF, and the ciliary neutropathic factors, which is the member of IL-6 family. Some cytokines also cause fever, formerly referred to as endogenous pyrogens. They are now called as pyrogenetic cytokines. Next slide, please.
Good morning, doctor. Good morning, everyone. Myself, Saiteja Vodala, and I am going to discuss the topic elevation of the hypothalamic set point by cytokines. During the fever conditions, levels of the prostaglandin E2, that is PGE2, elevates in the hypothalamic tissue and third cerebral ventricle. And these levels highest near the circumventricular organs, that is organum vasculosum of lamina terminalis, which includes the networks of enlarged capillaries surrounding the hypothalamic regulatory centers. And the key, when it comes to the key events of this, myeloid and endothelial cells are the primary types of cells produce pyrogenic cytokines. These cytokines include interleukin 1, interleukin 6, and TNF, that is tumor necrosis factor. And when these pyrogenic cytokines release into the systemic circulation, which results in fever, or when these will really when these enter the peripheral tissue, these PGE2, prostaglandin E2, will result in non-specific myalgias and arthralgias. That is, myalgias means muscle pains, and arthralgias means joint pains, which often accompany the fever. And once this prostaglandin E2 enters the circulation, we have four types of prostaglandin E2 receptors. But the third type is main one, which is responsible for the fever, that is EP3. When there is a release of prostaglandin E2 from the brain side of the hypothalamic endothelium, which further triggers PGE2 receptors on the glial cells. In the case of microbial products, toll-like receptors are responsible for this, and these toll-like receptor cells are similar to interleukin 1 receptors in signal transducing mechanism. And when these prostaglandin E2 receptors bind to the glial cell, their receptors, rapid release of cyclic AMP, that is secondary messenger, will be seen, and the and this may thought to and the cyclic AMP may thought to have a direct or indirect effect on hypothalamic set point. That is, and that finally results in the elevated thermoregulatory set point, as we can see in this mechanism. That is, the hypothalamic regulatory center accomplish heat production by inducing shivering and heat conservation through vasoconstriction, and finally it results in the condition called fever. Thank you. Next slide, please.
So now is a production of the cytokinase in the CNS. So cytokinase produced in the brain may account for the hyperplexia of CNS, hemorrhage, and trauma or infection. So viral infection of the CNS induce micrological or possibly neural production of IL-1 family or TNF and IL-6. In experimental animals, the concentration of cytokine required to cause fever is several orders of magnitude lower with direct injection into the brain. So substance or brain ventricle that with a systemic injection. Next slide, please. So as therefore a cytokine production in the CNS can raise the hypothalamic set point. So earlier understanding with our classmate, and bypassing the circumventricular organs. The CNS cytokine likely account for the hyperplexia of CNS hemorrhage and trauma or infection. Next slide.
Approach to the patient. physical examination. The chronology of events preceding fever, including exposure to other infected individuals or to vectors of disease, should be ascertained. Electronic devices for measuring oral, tympanic membrane, or rectal temperature are reliable, but the same site should be used constantly to monitor a ferable disease. Moreover, physicians should be aware that newborns, elderly patients, patients with chronic hepatic or renal failure, and patients taking glucocorticoids or being treated with an anticytokine may have active infection in the absence of fever because of the blunted febrile response. Next slide, please.
Approach to the patient laboratory test. The workup should include a complete blood count because it's used to treat for diagnose and monitor of different conditions. A differential count should be performed manually or with an instrument sensitive to the identification of julian or band forms. Because these band forms are known as immature neutrophils or stapes which are released after inflammation or injury. And Dolhi bodies, these are also known as inclusion bodies. These are like brown blue staining bodies in the cytoplasm of neutrophil leukocytes, and which are suggestive of the bacterial infections. And the neutropenia may be present with some viral infections. This is due to the decrease in concentration of neutrophils in blood. And measurement of circulating cytokinesis in patients with fever is not helpful since the levels of cytokinesis, such as interleukin 1 and tumor necrosis factor in the circulation, often are below the detection limit of the assay, or they do not coincide with fever. Because the cytokinesis that are involved in fever, like the cytokinesis function as mediators of fever. Moreover, they are acting locally within the damaged tissues or circulating factors in the brain. The primary endogenous pyrogens are interleukin 1, interleukin 6, and tumor necrosis factor alpha act at each of the sites and interact with nervous and endocrine systems to the modify host defense responses. Next slide, go.
However, in patients with low-grade fevers or with suspected ocular disease, the most valuable measurements are the C-reactive protein, CPR levels, and the erythrocyte sedimentation rate. These markers are of inflammatory process are particularly helpful in detecting ocular disease. Measurement of circulating IL-6, which induce CPR, can be useful. However, whereas IL-6 levels may vary during a febrile disease, CPR levels remain elevated. Next. Contributors. Thank you, Doctor.
Okay. Can you hear me?
Yes po, Doc.
Doc.
So thank you for the very extensive, actually it's really focused on the pathophysiology of fever and pain, no? But that is my concern when this topic was sent. I specifically asked because pain and fever are vague, no? It's when you have to consider it clinically, you cannot actually correlate them, unlike fever and rash, right? So let me just also share my slide because I asked Darius if I can focus on the pathophysiology of fever because I didn't get this slide beforehand, right? And so it will be unfair to you because some of the questions that I submitted for your exam will come from my slide. Okay, so I'll just point out those that are significant. Sorry. So wait. Oh my god, wait, where is it? Can you see?
Opo.
Okay. Okay. To concentrate on the fever. Ay, hang on. Ayan. So, we'll just skip this. So, the objectives. Okay, so you which is your thermal balance point. Wait lang. Wait. Mm-hmm. Okay, so earlier, temperature is controlled by your hypothalamus. And please take note, no, that the normal set point, of course, degrees Celsius. Okay. Already have discussed extensively, no,
Rock, we can't hear you.
your
You're choppy.
febrile response. So it involves your cytokines, rise in core temperature, and how can you hear me?
No, doc.
Wait, can you hear me now?
No, doc.
Choppy
No?
pa rin po, Doc.
Choppy,
Your
oh my
voice is
god,
breaking.
wait. Sorry, sino? Okay. Choppy pa. My other. Okay. Sorry, because is anyone here using USA TV as internet? I don't know why they don't have connection today. They
Medyo okay
didn't
na po din.
Ayan, medyo okay na.
Yes po.
Okay. Okay, let's resume. And di ba, I'll just make it quick. So, I'll just point out yung mga important. So, you've already discussed also this one, no? Yung, so, just remember, no? Your hypothalamus, when your body temperature drops, your skin vessels dilate, and then your sweat glands activate, and your hypothalamus activates cooling, and the opposite is for heating, right? When your body temperature increases naman, when your hypothalamus activates warming, your skin vessels
Can't hear.
you start to shiver, and then that's when your body temperature increases. Diagram of your mechanism of fever. Okay, this is important No, your mean oral temperature is 36.8. No, but please don't mind. Huh? Choppy again. Is it choppy again?
Yes, doc.
Yes, doc. Choppy po.
Wait. Is it choppy again, guys?
Yes, doc.
Hmm. Hello, can you hear me? Can you hear me?
No, doc.
No, okay. Oh my god. I'm sorry. Mm. I'm still choppy, guys. Sorry. I don't know why. The internet is internet from my phone. Slide, okay, because the exams were taken from the slides. Your presentation is really pathophysiology. Okay. I'll just send. Wait. I'll just send. Uh, Mm. Hello? How about now? Wala pa din?
Hello, Doc. Yes, we can hear you. Hello.
No. Okay, so I will just send the slide
Sige lang.
to Lara. And like I said in the chat, it's not so much into pathophysio, no? But the importance is to know how to clinically approach or diagnose your patient with fever and pain and your management. Okay? So I'll not take too much of your time because my internet is really problematic. I appreciate your presentation though because it's very extensive, very much into pathophysiology. But by this time, you should be concentrating or knowing already how to formulate your diagnosis and management. Okay? So I have in the mga differential diagnosis. Please look into them. Okay, so thank you everyone. I'm sorry for the very bad
Thank you,
internet.
Doc.
Okay lang. Salamat,
Totally
Dr. Saiba.
understand.
Salamat.
you,
Thank
Doctor.
you so much.
Okay, Doc.
Salamat po.
Thank you,
Thank
Doc.
you, Doc.
Thank you.
Thank you, Doc.
Thank